With regards to transplants, we're one of the leading centers in the world for multivisceral transplants. We have fantastic outcomes, especially in pediatrics.
Like what?
Like almost 100% with regards
No
to
way.
yeah, the
You mean
highest
multivisceral?
for multiviscerals. For pediatrics specifically, we have fantastic outcomes.
Wow. Well, welcome back to another PGA podcast. Today, I'm proud and happy to have here as a guest Dr. Stefany Hernández Benabe.
Yep.
She's the leading pediatric hepatologist at the University of Miami. And let's go. So we're planning to have a talk today about liver disease, infant cholestasis. We're going to go into more specifics as we move along. Why don't you start with a little bit of introduction of about yourself? I mean, what you had doing, what you had done, from where you're coming.
All right. So basically, as of December, I moved to Miami. Prior to that, I was living in the Orlando life, where there was plenty of Disney. And since bridging over to the very south, I have had a role that has been more focused on liver. In addition to that, I have a small role with regards to multivisceral transplants and whatnot. My main focus is both liver transplant and hepatology, aka patients who have liver disease. I truly identify my niche, what we call autoimmune liver disease, right? So primary sclerosing cholangitis, autoimmune hepatitis, those are my loves. And that's been ongoing for quite a while. With regards to what I'm looking forward to in this new position, it's really and truly being available and allowing to be a voice for the community and providing, everyone and anyone who needs any type of, liver help at any time.
So in terms of your pedigree, so my understanding is, so you did your fellowship in UM in gastroenterology, and then you have an extra year of training in pediatric hepatology.
Yeah, I did that.
In New York, Columbia University. And then you moved to Orlando and then back to Miami.
Yeah, it's very funny. I've kept to the East Coast, I guess. I'm an East Coast girl. You could say that.
Welcome to the warm.
Very excited to be here.
I would like to talk to you at the almost at the end of the conversation. Drive a little bit the talk towards liver transplantation. So hopefully we're gonna get there too.
Yeah.
First, I wanted to start talking about. So we're gonna talk about liver disease in infants or babies less than 1 year of age with liver disease, mostly focused on these terms that we call cholestasis, which is jaundice leading as a result of liver disease.
Yep.
Can you give us just a fast introductions of from your points of view, like the common cause of cholestasis that you see in your practice nowadays in infants?
Yeah. So, like when we talk about cholestasis, I want to really briefly mention, especially in the newborn age, right? Differentiating jaundice of a newborn as opposed to cholestasis, right? And I think it's essential that we identify that they're very different entities. For example, jaundice of the newborn being a completely benign entity, aka nothing bad is going to happen as long as we're looking at those bilies and making sure that we're looking at the chart with regards to the indirect hyperbilirubin. When we talk about cholestasis, the way I typically tend to explain it is when we have bile sort of stuck within the liver, right? And this bile is supposed to be flowing down the liver, down those bile ducts, and then into the intestine. But for whatever reason it is, whether it's a problem with regards to an obstructive etiology or reason, or whether it's because we have an issue that's microscopically or genetic, we see these levels of direct hyperbilirubinemia, that's direct bilirubin, where we see that the levels are pretty high, right? In general, especially during the first, few, like after the 2 weeks of life, we say that a direct bilirubin is not normal if it's greater than 1. And again, this differentiates from what we call the newborn or physiological hyperbilirubinemia, which is going to be an indirect hyperbilirubin that's going to be
So
predominant.
we have two different kinds of bili. The
Yeah.
one that hasn't been conjugated by the liver, that is floating mostly in the blood circulation, we call it indirect.
Yes.
Which is most of the times when that is predominantly increased, it's not due to liver disease, it's other factors.
Correct.
And but it leading to jaundice, exactly the way you say it. So the baby looking yellow. And then you have more the cholestatic type of picture when now the direct, the bilirubin that has to be conjugated and has to flow through the bile ducts up into the intestine, back into the blood circulation, in this enterohepatic circulation that is increased more than one, that it shouldn't be in babies more than
2 weeks, yeah.
than 2 weeks of age. Now, so you're seeing a baby, and now you know that the predominant or more than 2 weeks or 2 weeks of age,
Yeah.
with a direct bilirubin, let's say 2,
Yeah.
and also increased liver enzymes, but the baby's otherwise is doing well. It's gaining weight. It's very early. So how do you tease out, in your experience, what is what?
Yeah, I think the first thing you have to do is make an assessment of that patient, right? Do that physical exam, identify what's been the underlying, what's been happening with a patient, right? Is this patient a patient that's been very sick, for example, a newborn that was a premature and had sepsis or whatnot, as opposed to having a patient who was otherwise well and came to their wellness visit. And at the time of their wellness visit, the pediatrician became concerned and ordered that bilirubin. In general, there are many reasons for cholestasis, right? So these can be anything from infections or what we call genetic metabolic. We can call it like endocrine issues, like for example, having issues with thyroid. So it's a plethora or a very lengthy list of what we need to assess. When we talk about newborns, one of the most common reasons for cholestasis is going to be infections like urinary tract infections or UTIs. So definitely one of the first things that we're going to be looking at as well, if we're talking about the newborn, you want to make sure that the newborn screen was assessed and you want to make sure that you have those results. Now, I do want to clarify before we go further that the reason that I say direct bilirubin greater than 1 after 2 weeks is because prior to those 2 weeks, we want to make sure to look at what each lab or reference lab calls normal, right? Because each center is going to have different values and different machines with regards to what's considered normal or what's not considered normal within the neonatal age. So that's why I want to bring it up, because that's something that sometimes people don't really realize.
Yeah. But now you are getting the feeling based on results that the baby indeed has cholestasis and some liver disease is going on. Do you look at values of GGT or gamma glutamate transferase in these babies to tease out more like it's a hepatocellular predominant liver triggering cholestasis versus a cholangiopathy?
Yeah. That's definitely a very important lab. So I'm going to look at not just the bilirubin, right? When we talk about bilirubin, again, identifying the difference between the total bilirubin, indirect bilirubin, direct bilirubin. But what's going to be really important as well is that we look at a pattern with regards to liver injury, right? How are the liver enzymes? Is it just predominantly hyperbilirubinemia that we're seeing, or is it mixed? What is happening with the GGT? Is the GGT low normal when we have an elevated bilirubin? Because that can give you clues with regards to what's really happening in that liver. For example, you would think about if you have a GGT that's on the lower side and you have abnormal bilirubin, think about bile acid synthetic defects. So the pattern of injury definitely does give you information and allows you to move forward with regards to your evaluation, because it gives you clues, and you take each clue and you get to your diagnosis subsequently.
And now I believe also that nowadays we have most of the tool with very accuracy to identify like close to 90+% of all type of cholestasis in infants. I mean, back in the day when I started my career in the 90s, I remember that 60+% of the causes of cholestasis were not known. And we started calling those groups neonatal hepatitis.
Yeah.
But now with the pools of genes and panels that we can use, I mean, that unknown causes of liver disease in infants has narrowed down to we almost know everything.
Oh my gosh. I mean, science has moved forward so much with regards to research, right? You talk about, I don't know, 10, 20 years ago, we talk about PFICs, or progressive familial intrahepatic cholestasis, very, very long words. But in general, we didn't know the variability with regards to how many types of these we have, right? We started with one, then two, and then we've been able to capture so many patients and give diagnoses to patients based on genetic testing alone. So, science in general has advanced to such a degree that we're now able to give better care to the patients.
So you think that doing more genetics and having these turnaround results really soon, it has decreased the frequency of liver biopsies that we're doing in babies? Or?
Absolutely. I think that it has allowed us to be, or think about other less invasive modalities that we can provide to our patients. And, if you think about the ESPGHAN guidelines with regards to cholestasis, one of the first things that they're also mentioning is doing genetic testing. And I think that we all value as hepatologists and as GIs the importance of being able to tackle what's sincerely going on to be able to help the patient, right? Because if it's not the same thing to have a patient who has hypothyroidism as the underlying reason for their cholestasis as opposed to having a patient who, for example, has Alagille's disease. So it allows you to be able to direct the family with regards to expectations, provide better patient care. So overall, it's a win-win.
I saw a baby today for the first time in the NICU with already a diagnosis of Alagille's. And he is 3 weeks old.
Okay.
He's underweight. Cholestasis since the get-going. I think Billy now, I read Billy is up to almost 10 now.
Okay.
And then it happens that geneticists got involved early on.
Okay.
And the whole genome sequencing shows mutations within the Notch2 gene, which is very characteristic. But interesting. So I'm seeing the babies for the first time. So we know that he has a butterfly vertebra, he has posterior embryotoxins, everything, a whole picture. And actually, even I would say a little bit pronounced triangular face too, which is very early too.
Textbook, yeah.
It's very early. Because my understanding that facial features on Alagille's it come up late in life.
Yeah.
And then I ask in my people, how high is the GGT? Normal. So we are identifying a kid with Alagille's even before we are seeing anything florid. I mean, we kind of with that genetic results. We knew, but it seems like definitely it's helping us a lot, and we have a diagnosis.
That's fantastic. At 3 weeks of age, knowing, right?
Yes.
Knowing what to do with regards to, patient care and whatnot. And in general, we don't always have patients reading textbooks, right? And we are not always as lucky as having patients who have all the clinical characteristics with regards to their disease or genetic disease. So it's fantastic that you were able to identify it, and you were talking about poor growth or whatnot, or like he wasn't really gaining that much weight. That's fantastic that that we have Alagille's. We'll potentially need to target certain formulas that are, like, for example, higher in MCT, looking for those vitamin deficiencies that we have to be mindful about. So, I mean, kudos to science. That's what I'm saying.
Yeah, I agree with you. So even before we jump into genetic testing, so with labs we can have an idea. So if this is, again, primary liver disease from the hepatocellular injury versus a bile duct injury, and then you keep on your differential plus, imaging or no imaging plus the...
I think it would be hard as a hepatologist to say no imaging. At least I would want an ultrasound, make sure that, number one, have you excluded, for example, choledochal cyst, right? Number two, what's the patency with regards to the vasculature? Do we have any clots, for example, causing these elevations with regards to the liver enzymes? So I think you need things in general to be in a group and think of them as almost like a kit, because you want to get all that information yes, the labs will give you data, but you want to take everything together and exclude other things that definitely.
So now you're seeing these patients, and now you're getting concerns about, which I wanted to jump
Go ahead.
already into the terms of biliary atresia. So now you're getting a little bit concerns about biliary atresia. So you have genetics that in this case is normal. And so what would make you think on an infant 2 weeks old, 3 weeks old, that you may be dealing with biliary atresia?
Yeah, I mean, from my standpoint, it again, physical exam super important. The labs having a direct bilirubin that is perhaps uptrending, that is significantly concerning within the 2 to 3 week range.
Let me take you back on before we
go back
on the physical exam.
Yeah.
So aside of the jaundice, what else would you be looking at the physical exam?
I mean, you could have patients who have, for example, pale stools or what we call acholic stools. So these are pale, grayish, whitish. That would definitely be concerning for an issue with regards to biliary obstruction, right? Because the bile ultimately goes into your poop, gives the poop that brownish color. So that if there's any type of obstruction, biliary atresia could present that way, right? Not that all biliary atresias will present this early on, and I want to make that very clear. But if you do see that's an alarm sign or symptom that you should discuss with your pediatrician. From that standpoint, other things, irritability, for example. You can have patients that have significant hyperbilirubinemia that's direct, and they can become very difficult or very irritable because they have a sensation with regards to itching, right, or pruritus. That can happen not just within the first few weeks, but later on. You can have patients that aren't really gaining weight. And you see that, like, with regards to their growth chart, they're just either stagnant or slowly downtrending. You can also have, patients who are overall not meeting the expectations that we would typically see with regards to the hyperbilirubinemia. Again, going back to that, I apologize, that's a love topic for me. You would expect, for example, if there's a physiological jaundice of the newborn, that yellowing of the eyes or the sclera, right, to be subsequently improving, not worsening. So that could definitely be a sign or symptom that you'd be looking for. And the most recent guidelines from the AAP are trying to shed light that we shouldn't necessarily just concentrate on the skin color, but again, focus on the eye color, because that in itself can alert us with regards to underlying liver disease.
So now we have acholic stool, cholestasis, let's say high GGT, I mean something above 200 or 300 range. What would you do next?
Oh, I love this question. So, I definitely have the ultrasound done. Why? Because sometimes there can be findings in the ultrasound that can suggest biliary atresia, like a triangular cord sign, for example. Not that an ultrasound, I want to be very clear, not that an ultrasound would ever exclude biliary atresia, but there are times where you get that miracle answer right off the bat, right? So from that standpoint, you could get the imaging. There are other markers that we can also sometimes consider when we're talking about biliary atresia that are like the MMP7 as well, typically high in the patients with biliary atresia. When we talk about evaluation, I'm of a school where I know this may be a controversial topic, HIDA scans.
I'm gonna get you there.
Not
yet.
Oh, not yet. Okay.
Usually, what I like to do on my patients, I wanted to make sure that the ultrasound was done fasting.
Definitely.
At least 4 hours fasting on that baby, to have the gallbladder full or bile, and have a good visualization with the ultrasound of the gallbladder. I believe the sensitivity of that ultrasound in babies who are with acholic stool, high GGT, and cholestasis, and they have some irregular atretic gallbladder, small gallbladder, non-visualized gallbladder on the ultrasound, fasting ultrasound, raises a lot of the suspicions of biliary atresia. So now going back to the HIDA scan or biliary scintigraphic, what would you do next with the ultrasound findings? Would you go for for the height scan, or would you go for a liver biopsy, or would you call the surgeons?
So I'm a little bit controversial in that aspect. I do not go for the height scan.
I don't do height scan.
You don't? Oh,
I don't do height scan.
Okay. So
Personally, I don't do. I mean,
I don't
very
do them
rare
either.
that I would do it.
The problem, okay, so for whoever's listening, the problem with HIDA scans is that they can be positive. Positive means that we don't have excretion of that contrast that is placed during the study or whatnot, and that can make you think you have biliary atresia when it's not really biliary atresia. You can have a positive HIDA scan, for example, with someone who has alagioles, and that can, mix up the picture. So in general, I am one who would recommend IR, guided liver biopsy with a cholangiogram. Why? Because it allows me to be more timely with regards to getting the information of, is this biliary atresia or is this not biliary atresia? Granted, it's very center specific in the sense that if you don't have an IR physician who's comfortable doing these procedures, that can be a limitation where HIDA scan would potentially have a role. But I go for the liver biopsy, and I definitely go for the cholangiogram early on. And if I have the information then and there with regards to biliary atresia, then we go ahead and plan the surgery with our surgeons. Sometimes other approaches include, if you don't have that interventional radiologist, just going then and there for having the intraoperative cholangiogram.
No, it makes sense what you're saying in terms that you don't have to use the surgeons to use the intraoperative cholangiogram. So AER is just going to be probably, but you have to have that team.
Yes, you have to have a multidisciplinary team. And I think that's the essential thing, where there's an understanding between like the surgeon, the hepatologist, interventional radiologist, that we're all working as a team and that we're all aiming to get answers, right? Because if you can avoid a larger surgery, why shouldn't you? Why shouldn't you go down the IR path, right? Yeah. And with regards to a liver biopsy, you're going to get that liver biopsy at the same time. It's a procedure that maybe takes 15, 20 minutes. You get your answers, bam, bang. And you can ultimately feel comfortable subsequently evaluating the cholestasis if it's not biliary atresia, because as you know, like when we talk about biliary atresia, it's essential that we talk about timing, right? The earlier you diagnose, the earlier you manage it surgically, the better the outcomes.
Yeah, so that's the other question that I wanted to ask you. So in this cholangiogram, now that they're getting report that this extrahepatic biliary atresia is all atretic. Yeah. The whole picture is definitely pointing towards biliary atresia. You get your liver biopsy that it points towards biliary atresia as well. So in terms of the outcomes for a good Kasai portal enterostomy, so what is the latest guidelines in terms of when the patient should be referred, how soon, and what is the outcomes based on when the patient gets into the table to have that Kasai done?
In simple terms, the earlier the better, right? Why? Because when we have biliary atresia, it's all about the inhibition of that bile flow down those ducts, and that bile accumulates within the liver, causing inflammation and causing fibrosis or scarring of the liver. So we know that outcomes are significantly better the earlier on we do the Kasai as opposed to waiting. So in general, our goals are to do the Kasais within the first month if able, which is why I say it's so important with regards to timely diagnosis. And just going back to the guidance that was just printed out this year with regards to biliary atresia and cholestasis from the American Academy of Pediatrics, we're now moving to a place where within the 2 to 4 week wellness visit, they're asking that we focus on those signs and symptoms that we were just speaking about, having the yellowing of their scleral icterus, having those pale stools, and if the patient's already had prior labs, reviewing those labs that were done, for example, in the hospital with regards to that bilirubin or direct bilirubin. If we see that the labs then show a bilirubin that's direct that is less than before, this is very likely not a case of biliary atresia. I would not expect a patient who has biliary atresia as well to have a direct bilirubin that is stagnant. I would expect it to be increasing. This is a progressive disease that happens congenitally or intrautero. So from that standpoint, the earlier the better. So that's why we need to identify this diagnosis with a pediatrician and then have a timely referral.
So surgeons still are doing Kasais up to 3 months of age.
Yeah.
So even though the outcome is going to be less.
Yeah, the outcomes are less definitely, but because you want to give the patient a chance, right?
Yeah.
if you don't do the Kasai, then, like, for example, I've had patients who come in and are diagnosed at 4 months of age, right? They already are cirrhotic. So we do what we call a primary liver transplant. So Kasai isn't even considered. And 3 months of age, again, there are some patients that have a little bit more luck than the other, right? We also know that outcomes are going to depend not just on luck, surgeon expertise, for example, and overall what's been happening in each patient's liver. Ultimately, we want to give patients a chance because we do understand that transplant is such a hefty option.
And then in terms of outcomes as well, do you look at that liver biopsy, the amount of fibrosis, pre-Kasai, or the levels of bili? I mean, something that will give you a clue aside of the time of presentations for better outcomes or not after Kasai.
Yeah, we always look at the liver biopsies and see what stage we are with regards to fibrosis, right? I always bring it up to the parents when we're talking about the Kasai because I want them to know expectation-wise, right? We're going to give this a go, but if we have stage 4, aka cirrhosis, then there is a high possibility that we're going to turn into that. When we talk about biliary atresia, we talk about the 1/3, 1/3, 1/3 rule, right? 1/3 will get their Kasai, will do fantastic. 1/3 will get their Kasai, do well in the beginning, then not do so great. And then 1/3, the other 1/3, is that population that get the Kasai and we really don't see any improvement with regards to biliary flow. So I always bring up the scarring because I tell them, hey, these are the stats. And this is where we are specifically with this liver biopsy, identifying that it's a small piece of the liver, right? That liver disease is not homogeneous, aka it can be a sample error as well. But I think that ultimately we all want to try to avoid transplant if we can, and obviously give the kiddo a chance if we're able to avoid it.
So the surgeon is telling you that during Kasai, he got to see a good flow at the time of the Roux-en-Y and reconnection. So what is a follow-up that you do on these babies after Kasai?
Yeah, so after I get the call from the surgeon saying there's flow, after the happy dance, basically we start talking about starting medications like what? For example, we'll start ursodiol. Ursodeoxycholic acid is a medication that allows the bile flow to be easier, quicker, the bile less dense. So we typically will start that medication. During the first few year after the Kasai, we'll also talk about starting an antibiotic for what we call cholangitis prophylaxis. There are different antibiotics. We use this because we know that if patients have recurrent episodes of cholangitis, and cholangitis, what that means is an infection within the bile ducts, right? We use an antibiotic to prevent underlying recurrent episodes because these infections within the bile ducts can actually develop into bacteremias, right? So from that standpoint, we use these antibiotics. We also use the vitamins.
So the antibiotics you use when you're suspecting cholangitis or before suspecting cholangitis prophylaxis?
For the first year, in general, I do use them as a prophylaxis. So a very low dose with regards to the antibiotic.
What prophylaxis are you using?
I typically start with Bactrim. Okay. During that first year. And obviously, if we have what we call breakthrough...
Because I'm not sure it's strong data that it prevents much.
It's a very controversial topic. Yeah. Yes, but to this day, we still continue to use it.
I learned a long time from an infectious disease doctor in my fellowship. She used to say, you can do prophylaxis for urinary tract infection because you can clear the urine. But in cases of ascending cholangitis, that the infection is going to come from your poop or your microbiome, you will never be able to sterilize the intestine.
Yeah, and that's correct. But from our standpoint,
so you use
the reason I use it is because yes, for sure. The reason I use it, not that saying that that's the only medication I would use because there's other antibiotics, but I use it because we know that having recurrent episodes of cholangitis is going to be a reason for liver transplant.
Yes.
So during the first year, especially, I will keep on to that prophylaxis. And then after that year, if the patient hasn't been having recurrent episodes of cholangitis, I will stop the antibiotic. But again, this is something where like the patient and the physician have to have very close relationships, right? Because we need to see both that the patient is growing, where we assess, growth. One of the things that we'll talk about high medium chain triglycerides or MCT oils. We'll talk about
Which
formulas.
is part of the nutrition too that you
Correct.
mentioned already. So you focus on the weight growth of
Growth.
these babies, and then you say before liposoluble vitamin deficiency.
Yes.
And the right formulas for these babies to grow well.
And the growth is because, again, that's an indication for liver transplant, right? Not giving a patient so many calories, more than a patient's supposed to at that age. And that happens because our underlying liver disease is just so severe. Our liver is responsible for the absorption of certain nutrients, vitamins or whatnot. So sometimes it's just that liver disease is quite severe. And then no matter how many calories you're throwing at the patient's not really growing. So that sort of pushes you to talk about doing enteral feeds or feeds via nasogastric tube, or TPN, which is nutrition via IV. So it's pretty dynamic, and each patient will have a different story from that standpoint.
And so in terms of the urso dial, I mean, I always like to tell the story because urso, it comes from the Latin word of bear.
Yes.
And that actually is a medication that it's used as a medicine now, but the Chinese has been using for more than 2,000 years since they isolated wild bears back in the days. I think they still use in the blood marker. So nutrition, ursodiol. How long would you use ursodials in this baby? For how long?
I usually will have them on the ursodiol for a prolonged amount of time. I don't have for example, I don't say we're going to be on ursodiol for 2 years. I look at the labs. I see what's happening with the GGT. I see what's happening with the bilirubin. If I have a patient who did fantastic with her Roux-en-Y and has been on ursodiol for 6 months, 8 months, and the labs are pretty normal, that's a patient I will challenge without ursodiol and see what comes about. Obviously, maintaining, doing the labs and seeing how he's, clinically evolving. So there's no guideline with regards to how long we're going to be using the ursodiol. It's very patient specific.
So still, biliatritis is the most common cause of liver transplantation in pediatrics.
Yes.
And it's a condition that we've been aware in kids for a very long time. But I want to take you back to the beginning. It has been more clear to us lately in terms of the causality or the physiopathology of biliatritia, why it happens, why biliatritia occurs.
Yeah. I mean, there's different hypotheses, but to this date, we don't have anything that is straightforward that we can associate it. Right? When we talk about biliary atresia, there are also biliary atresia with subtypes with regards to splenic malformations and things like that are more so associated to genetic abnormalities, or we suspect are more so associated to genetic abnormalities. But there are many hypotheses, and to date, we still don't have standard answers that I can give to my patients. But it's an area of research because really and truly, if you look at different areas, for example, Japan has a much higher incidence of biliary atresia as opposed to that's reported in the U.S. The U.S., we typically say that there's, a lower incidence as opposed to Asia. So in Asia, for example, that's prompted stool screening cards for when patients are being discharged from the hospital, for parents to know what pale stools mean, right? So that in itself has brought upon earlier diagnosis of biliary atresia and ultimately, earlier interventions and better outcomes, I would say.
So my understanding and what I'm trying to explain to students and my patients is it seems like most of the disease, I mean, you have an initial injury.
Yeah.
And that can be an infection or a genetic predisposition toward it that it dysregulates your immune systems and create fibrosis or that. But exactly why this happens, the mechanism, we haven't been able to tease out much.
I think that from an advancement standpoint, previously we said you were born, you potentially were born with it, potentially not, potentially evolved after you were born and a few weeks after. I think there's more data showing that this is happening intra-utero, which is why we're able to identify direct bilirubins that are earlier on within the first few days of life, and that can track back to having those patients with biliary atresia. So we've advanced from that standpoint, but not really chewing what the exact trigger is here.
And I was asking you before the podcast that I was reviewing last night, and I came across 6 different genes, mostly involved in the bile duct remodeling, the cell signaling, the matrix transmembrane signaling, the ciliary movement within the bile duct. I mean, all, but it still, even though there has been some looks like links of this gene towards biliary atresia, there hasn't been proof that this is a causality idea, and all these patients have these mutations. So we don't have, I mean, on this genetic panel for liver disease, we still don't have screening on the genes that may be coming along the link or not to biliary atresia.
Yeah, that's completely correct. The majority of cholestasis panels that we have available don't target that specifically. But even now, what the SPGAN guidelines are sort of pushing us to is to talk about whole exome sequence, talk about more deeper, more information for us to be able to identify the reasons for underlying cholestasis earlier on. So I think we're moving towards that path. I think that most of the cholestasis panels initially were very small, and then subsequently we've been adding more and more and more and more genes. So I think overall that's going to be the pattern that we're going to be seeing during the next few years, which is fantastic if you ask me.
So going back to the treatment, that issue that we ran across a few years ago about using corticosteroids as an anti-inflammatory.
Yeah.
Post-Kasai, we are over that. So
Yeah.
we're not using corticosteroids any longer.
No,
So,
there was a meta-analysis, 2015, I want to say, that showed, at least in the U.S., that there was no use for the corticosteroids, and for that reason, we've moved away.
excellent. And so now in terms of outcomes, so most infants that are picked up earlier, they get a good Kasai, a good bowel flow, and treatment. So the outcome seems to be pretty good in terms of maintaining a healthy native liver.
Yeah, definitely. And obviously, it's going to be very much patient dependent, but the earlier we grasp this diagnosis, the better we tend to see outcomes with. So having a diagnosis of biliary atresia, I want to make sure that people understand it's not equivalent to like a liver transplant. I think that's sometimes a misinformation. But we just need to be aggressive with diagnosing it early on and then allowing that liver to have less scarring or less fibrosis, because ultimately that is very important.
So in terms of moving towards a little bit more the transplantation part in biliary atresia, so it still is the most common cause of liver transplantation in pediatrics in the world.
Yes.
And I believe the percentage of liver transplant due to biliary atresia overall, only on biliary atresia, is 40+%. So most of the liver transplant still is biliary atresia. So what makes you concerned or to list a patient, pediatric patients towards liver transplantation, or put on the list towards liver transplantation? You base what do you base your decision on?
My decision is going to be based and looking at the labs in the sense of that INR. If we're giving that INR is abnormal, we're giving vitamin K, the patient's not really responding. INR is a reflection with regards to liver function as well, right? If we don't have vitamin K deficiency. So if we're starting to have abnormal INRs, if we're starting to have patients who aren't really growing, if we're starting to have patients who are having ascites, right? That's already decompensated liver disease. Ascites is a point where our fluid builds up within our abdomen, right? Our liver is responsible for creating certain proteins that allow the fluid to stay within the vessels and create what we call oncotic pressure in scientific terms. So when we start having evidence of ascites, when we start having evidence of GI bleeding, what we call, for example, varices, right? So you can.
So both would be more like a signs of portal hypertension. Meaning that liver is carrying more.
Yes.
And even though the function may be good or not,
yeah.
So that portal hypertension by itself in a baby can lead into to listing a baby for transplantation.
Definitely, and from that standpoint, we want to be able to identify those factors earlier on, to list the patient, right? And provide that liver before they decompensate too, like they're too further along with their, with their liver disease. Because unfortunately, within the waiting list, there's still stats from 2023, which is from the SRTR data, that are showing that we have a percentage of patients that are waiting for a transplant, and they're in the list, that are either too sick to undergo a transplant or die in the list. And that can be anywhere during the past few years, anywhere from 5 to 10%. For me, 2025, that's unacceptable.
Yeah.
Which is why, at the Miami Transplant Institute, we provide living donor liver transplants as well, to allow patients that opportunity of not having to go down that route.
Yeah, we're gonna talk about that part too. Portal hypertension and liver synthetic function, which is a coagulation predominant, and then just the billing, how that cholestasis is getting worse or better. Later on, in late or in teenagers with biliary atresia post-Kasai, are you seeing often, or are you seeing the complications like hepatocellular carcinomas on those babies too? I mean, would you screen often too?
Oh, yes.
On
Yes. So when I know a patient is cirrhotic, I'll be screening with alpha-fetoproteins or AFPs every 6 months, tracking to make sure that I diagnose HCC or hepatocellular carcinoma earlier on. Now, AFP by itself should not be the only marker that you're looking at, right? So at a minimum, you would want to do ultrasounds looking at the liver tissue,
how
right?
often would you recommend?
I typically do
in
them.
cirrhotic patients with biliary atresia.
So if you look at the adult guidelines, they're going to say to use AFP and to use the ultrasound modality at least every 6 months. In pediatrics, there's no guideline that specifically says either 6 months or every 12 months. I am a little bit more aggressive, and I'll typically tend to do it every 6 months because I understand that the earlier we diagnose HCC, the better, right? Because when you have this type of cancer, it can metastasize to certain areas. And if you're able to grasp this complication earlier on, then you can potentially help with a patient with a liver transplant or local resection if it's small enough and with chemotherapy or whatnot. So that's why I am aggressive. But unfortunately, most of our data, or fortunately, I should say, most of our data is focused on adult data. And we sort of mimic those recommendations.
And then also in terms of portal hypertension, when or how often would you scope or tend to scope these patients to look for varices or if they are prone to bleeding or not?
That's a very good question. So in general, I tend to use a combination of using fibroscans, and I look at CBCs, looking at the platelet count, looking at the white blood cell count, right? The white blood cell count and platelet count will start downtrending when we have significant splenomegaly. With the fibroscans, we're able to track fibrosis in an indirect way. And I unite both, and if I'm seeing that the fibrosis is becoming moderate to severe, and we're having thrombocytopenia or low platelets, leukopenia, that's when I'm going to start screening. If I screen and I see that there are no varices, that's fantastic. I'll potentially rescreen in 2 years unless the patient has any symptoms or worsening, acute worsening. If the patient does have varices and they're small varices or grade 1, I'll repeat a scope maybe in a year, again, unless the patient is having anemia subsequently that I can't really explain. And then obviously if we find varices that are either bandable or sclerotherapy, I can use sclerotherapy for, I'll be following up quite much more recurrently, making sure that I'm able to treat them. So I'm in the primary prophylaxis team, and that as well is a very controversial topic. But if I see a patient who has a esophageal varix that's quite enlarged, I will place that band and with the hopes that we can avoid that bleeding.
Last year, I referred a patient to you that I've been follow up with biliary atresia post-Kasai. I believe she was, when she got to you, it may have been 14, 15 years of age. I lost her in follow-up for like almost a year, and then she shows up into the ER with fainting episode. Then it happens like she was exposed to cannabis, and so we got the history got a little bit confused, and it was all blaming to cannabis. She was positive for cannabis.
Okay.
And she was discharged home. I was not involved. Then she comes back for the second time. Now, no cannabis anywhere.
Oh no.
And it happens that the oxygen saturations on her was super low. So she got an echo, and we came out with hepatopulmonary syndrome. So in these patients with biliary atresia and fibrosis or cirrhosis, like your index of suspicion, so how often would you check O2 SAT in terms of recommendations for the follow-up in this?
Every clinic visit. So for me, every clinic visit, if I like having a vitals, not just looking at the weight, the height, making sure that I have that O2 set. If there's a suspicion for it, I will automatically order a bubble echo, right? To look for hepatopulmonary. And that in itself as well is an indication for liver transplant. That's how you're going to cure that hepatopulmonary. So it's important for us to be looking at those numbers, not just looking at the labs.
Yeah, because I mean, all these complications that we mentioned, like hepatopulmonary syndromes or hepatocellular carcinoma, it raises your scores towards moving fast towards liver transplantation.
Absolutely. That's how you're able to get exception scores when you're listed. There's a set criteria with regards to how we get those exception scores that are set to allow the sicker patients to get the organs. Because sometimes, unfortunately, your numbers, your score, whether it's the MELD score or the PELD score, those are the scores that we use to list a patient for a liver transplant, right? If it's PELD less than 12, MELD greater than that age. And sometimes the labs don't really give the full story. So we as hepatologists, as GI, need to request exception for these patients to get more points, because we understand that their mortality is much higher than what the score alludes to.
So I wanted to ask your opinion on, we are going back to the beginning of biliary atresia again, in terms of diet and maternal diet and breastfeeding. And the microbiomes of baby. I mean, I'm aware there is data on human data and animal data showing that if moms are exposed to a fast food diet, that baby may come out with an no breastfeeding after birth. That baby microbiome or a lot of intestinal bacteria may change towards a more aggressive type of microbiome or bacteria that promotes inflammation or dysregulates your immune systems. Some people call it gut-liver axis, something like that. And actually, we were checking that is a recent publication in JPGN, I think it was this December. I know Ben Schneider was the last author of a group in Texas, that they look into kind of outcomes on biliary atresia on babies on formula and babies on breast milk. They didn't see much of the difference in terms of survival of that liver. So you had Kasai, so being on breastfeeding didn't make much of the difference. But it seems like a baby on breastfeeding post-Kasai, the bilirubin tends to drop faster, and they grow better.
Yeah.
So you are forward towards breastfeeding a lot on these babies, and
as long as they're growing, because at the moment that they're growing and we're supplementing, for example, that breast milk, and they're still not growing, I will transition to a formula that has high MCT oil on purpose, because when we talk about MCT oil, our liver doesn't need to break that fat down. So you're going to be able to absorb it and get those calories adequately. So I am all for breast milk as long as we're growing.
But you haven't come across anything related to the abnormal microbiomes and leading to biliary atresia early or anything like that?
No, but I feel like that's what's going to happen in the next few years.
Yeah, it looks like. No?
Yeah.
I mean, it makes sense. It's
It
a
does.
common sense. Now, going back to outcomes, so how busy is the liver programs at UM in terms of transplantations, multivisceral transplantations, biliary atresia? So what are you doing there?
Oh my gosh. So with regards to transplants, we're one of the leading centers in the world for multivisceral transplants. We have fantastic outcomes, especially in pediatrics.
Like what?
Like almost 100% with regards
No
to
way.
yeah. the
You need
highest
multivisual?
for multiviscerals. For pediatrics specifically, we have fantastic outcomes.
Wow.
So
So it seems like your guidelines to picking up patients, the right patient for transplantation, for multivisual transplantation, it changed a lot and it's improved.
it definitely has improved, and I allocate that improvement to the team.
Yeah.
That
We are
team
not
that
talking about biliar atresia, we're talking about multivisual
yeah.
for the people who are not used to this topic.
For biliary atresia and for any liver disease, we do provide either deceased donor or living donors. With regards to deceased donors, our outcomes are similar to the national average. So we're great from that standpoint, which is about 90 to 93% survival during the first year, and there's more stats subsequently. That's all available, again, in SRTR. With regard to living donor, I will say that there is now more data coming from centers in the US showing that we're having fantastic outcomes, even superior to the deceased donors. So there has been significant interest with regards to having that part of the transplant grow. With regards to numbers, around 15 is where we're at annually, which is what we would call a medium to large sized program. But again, we do multiviscerals, we do isolated intestines, we do livers, we do multi-organs.
But intensive survival, like organ survival, post-transplantations and patient survival, you're not seeing much difference or better the outcomes in living-related versus non-living-related transplantation? So,
according to the SRTR data, yes, we are seeing improvement with regards to both graft and patient outcomes with living donor liver transplant. So overall, that's whether it's because we're able to get patients in the OR when they're less sick, when they're in a more controlled environment, where we're able to prepare for the surgery with more caution, to be determined, but in reality is that the outcomes that we're seeing now are significantly different to what was published earlier on in the 2000s or earlier on when we were starting living donor liver transplant, right? So it's fantastic to see that these numbers are comparable and that it's a good option that when we go and we're talking about transplant, patients, parents should be an advocate and ask about living donor. Ask about, what are their options for their children, because this is a good route to take as well.
So you mentioned the talk, and I'm going to go back to it, and I'm going to beat Jennifer on this. Hopefully, I'm hoping to have her soon here.
That's the boss.
Our intestinal rehab and multivisual intestinal transplantation. So, but you mentioned, actually, I'm perplexed with the stats that you gave us. Because mortality of multivisual transplantation, back in the day was 50-50.
Yeah, that's...
And at some points we decided a long time ago, we say, rehab, you're going to do better intestinal rehab, so what's the point of doing any type of transplantation? But I always stuck in my mind a conversation with Rodrigo Viana, your transplant surgeon, your lead transplant surgeon. And he said one to me, I'm going to refer to you a patient post-transplantation who is very sick, and I want you to maintain him alive. And because that's what gastroenterologists are doing to us. They just wait so late to refer a patient for intestinal transplantation or intestinal transplantation evaluation that patient is so sick that when he goes to the table, the outcomes of that patient is going to be horrible. Which is, early referral, and it's important for that multivisual transplantation. But still, 100%.
Yeah, again.
Wow. Like how long? Like 1 year?
The 1 year. I'm talking about 1 year.
But still, it's very good.
It's very good.
So you're not seeing much rejections or intestinal rejections on those patients with multivisual.
So there have been significant changes with regards to
like
protocols and what medications we're using as opposed to 20 years ago. So I think that definitely has led to variability with regards to outcomes that were previously published.
And you're part of that team too with Jennifer or Jennifer. Yes. So yeah. I know that you're more involved with liver, but you both see the multivisuals too?
Yes. In fact, today we just accepted one for pediatrics. So we'll be having one happening either tonight or tomorrow in the
Yeah.
morning. But yeah, I think it also has to do with
And again, I mean, for the audience, it's more like a intestinal failure with that. Now the liver is burned out, usually for infections, TPM, so on, so on, so on.
the only thing I will say that I think we've also progressed from a nutrition standpoint, from an intestinal rehabilitation standpoint, that has allowed us as well to see improvement for outcomes. I think, a few years ago, we didn't know the validity or how helpful having Omega-Vin, having SMOF on board, identifying, what we could do to help with regards to intestinal rehabilitation, as opposed to just giving nutrition and not really identifying that, having TPN that's high with regards to glucose infusion rates can cause such harm. Promoting the use of enteral feeds, whether it's very minimal, has definitely led to improvement with regards to patient population. And I think intestinal rehab has definitely advanced during these last few years, and that has definitely allowed us to have a different patient population to what was available, or what was the bread and butter, I should say, in the early 2000s.
Excellent. Anything else that we should talk about biliary atresia or your liver transplant program?
I think that, what I would like to share with everyone, we're here to help. We're your liver program, your local liver program or non-local liver program. We are a fantastic team that is always able and willing to see.
Yeah, you're seeing patients from all over the country too.
Yes. We're more than happy to get, referrals and welcome, having that multidisciplinary team with GI and transplant, because ultimately what we want is what's best for the child. And, we have the services, so we want to provide them.
No, I can testify for that. I mean, you've been very helpful with my patients, very sick patients, in terms of managing their evaluation for transplantation, post-transplantation. So I have to thank you for that.
No, thank you. Thank you for inviting me here. I am beyond ecstatic. It's been a huge privilege. Thank you.
It's a pleasure.
All
Thank
right.
you.
Thanks.